Good morning or good afternoon. I guess it's after 12. I'm going to apologize. I have a bit of a cold, so I'll do my best. So what I'd like to accomplish today is really look at the last 10 years of emergency medicine and how it's evolved in terms of performance and kind of the way it's been set up. So I'll touch base a bit on what the ED is like for those of you who haven't worked in that environment. We'll look at the last 10 years of how the functioning has evolved. After that, I'll discuss a little bit about the GEM program and different evaluations and talk about the future direction of where the GEM program is going. So the emergency specialty is a newer, younger specialty. Really came to be in the 1970s. There was no formal training prior to that. And in 1972, the Royal College actually accepted it as a specialty. In 1978, the Canadian Association of Emergency Physicians actually came to be, followed by NENA, our National Emergency Nurses Affiliation, and then recognizing the nursing specialty in the 80s. And the goal of emergency medicine is really to see those unplanned, unscheduled visits, focusing on acute care, acute injury, really the first receivers to do those interventions for those critically ill, and the first point of contact for the healthcare system. Other things that we talk about in terms of emergency medicine is that they're the jack of all trades. So many emergency departments are recognized as stroke centers or as trauma centers, first responders to code oranges, which is mass casualties, poison centers, and also if there's exposures to chemical, biologic, radiation events as well. When we look at the actual ED process on paper, it doesn't seem very complicated. There's an arrival time where the patient presents to the ED, either on their own or by ambulance, escorted by family, police, and then there's a triage process, which I'll go through in a bit more detail. There's a registration that occurs, which is essentially where the chart happens, the process of care, which is all the assessments, diagnostics, consultations, treatment plans, and then lastly is the discharge piece, which is essentially the patient leaving the ED or being admitted or being transferred somewhere else. Now, when we look at the word triage, obviously it came from French roots back in World War I and II. It was essentially created so that they can get the healthiest soldiers who needed the least amount of intervention back onto the fields to actually fight the wars. And it gave a process of classification, prioritization to patients, depending on how urgent their condition was. Now, in the medical intent of triage is essentially the inverse. We're trying to put the most resources for the sickest patients out there. It was introduced in the 1960s, and it got improved over the years, especially as Medicare became free and people then could come seek health care, and they actually started visiting hospitals in order to get that. There was a 3-tier system in the past, which was emergent, urgent, and non-urgent, and other variations of that depending on the province and areas you lived in. And then we became a bit more refined in terms of creating a better adaptation of it, and that was adapting the Australian model of a 5-tier CTAS, a triage system. It was accepted by all the governing bodies for emergency medicine and nursing. And in 1999, there was a formal rollout of the Canadian Triage and Acuity Scale. It was revised many times, and now it's even gone electronic. So what does this CTAS really look like? So it's 5 levels of care, one being resuscitation, where they need emergency interventions, emergency nursing, and physician care, all the way down to 5, which is less urgent or non-urgent or deferrable. The triage process is essentially a critical look, a quick eyesight to see how the patient is doing, infection control screening, which I might have failed yesterday, had I done it yesterday. Their presenting complaint, and then modifiers to help justify different decision-making. So by creating a standardized triage process, we're better able to have a standard across all of Canada, improve care, improve reliability and validity, have benchmarks nationally. So really using the triage, that first initial on point, to actually decide how sick people are and keep that as a value for your organization. Knowing that this CTAS will also make sure that the sickest get the services first, and really identify how we could distribute services and allocate people different areas of the emergency department. So the question is, what happened 10 years ago to today? How have things evolved over the last decade in terms of emergency medicine? So overcrowding is defined as a situation where the demand for emergency services actually exceeds the care in a reasonable amount of time. And there's been lots and lots about overcrowding that's been documented over the years. It became prevalent in the 1980s and worsened in the 90s when they started closing hospitals down and closing acute care beds and even some emergency sites. We were affected by this as well here at TOH. And there was an article in the Citizen in December 2017 where they had interviewed at the time the president of CAPE, so the Canadian Association of Emergency Physicians, Dr. Alan Drummond. And what he stated about overcrowding is that he said, word for word, crowding has been allowed to pervert the delivery of healthcare since the mid-1990s. Contrary to wild held views, crowding in the ER has absolutely nothing to do with inappropriate overuse by patients presenting with non-urgent problems. So knowing that that's basically what has been occurring over the last decade, we actually started feeling pressure from the ministry in terms of changing the way we deliver care. In 2008, the ministry decided that they would put ED wait times on the radar and try to decrease them and make improvements over 4 years. What they found was in 2008 and 9, actually the EDs were used 6% more, but cost over 28% compared to 2004 and 5. So it was becoming way more expensive to deliver care. There was also questions about the quality and efficiency depending on the different institutions. And at that point, all hospitals had adopted the CTAS model. So they were all triaging in the same way. So ensuring that everybody was actually documenting and capturing the right information and using modifiers. And at the time also the 14 LINs were responsible for the different funding and initiatives that would happen. So this strategy led us to the Excellence Care for All Act in 2010. And it basically adopted a system where there was an expectation that people had to perform in order to get funding. There was accountability to hospitals to do these types of things, and part of the program also included an ED process improvement program, or we call it the PIP program. Those who've worked in the ED remember PIP very well. It's still something that's strong and going. Though the PIP leads at the time were a clinical manager and a physician, and they would look at how they could improve patient flow using lean transformation. So they would have all the frontline staff, or as many as can attend, in a room. They'd go through step-by-step process to see how do we get from A to Z and what can we cut out or make more efficient in order to meet our targets, which is to reduce the amount of time patients spend in the emergency department. How can we get the care more efficient with using less? So our lean methodologies were used starting in 2008, and they're still going strong today. And the goal was really creating a sustainable improvement process that can flow within the hospital. At the time, in 2008, it was a volunteer system. Hospitals enrolled because they were interested in improving. And then over the years, it became mandatory. So that's what we call our pay for results, P for R. So the goal essentially is always to reduce wait times. And the first initial hospitals that went through this, including the Ottawa Hospital, we had a decrease of overall wait times by 4.7 hours for the really sick who ended up getting admitted or being discharged, and a decrease by 1.4 hours for the people with minor conditions. So essentially, the program that they put out and the interventions actually worked. And at the time, the Ottawa Hospital became one of the top 5 performers when we started doing these initiatives. In 2010, the program expanded to 71 high-volume, high-demand hospitals. And how it worked at the time, there was about $100 million. $60 million would go towards the hospitals themselves to make those projects happen, and $40 million were incentives. So essentially what the theory was is that the better you perform, the top performers actually get more money. So there was always a drive to do better and to actually drive our performance so we can get more funding. So the recommendations from the ministry at the time were to ensure that we're operating obviously in a cost-effective way with high-quality care, not necessarily cutting corners, but being more effective at what we're doing. Ensuring that the quality of triage is up to standard. We want to make sure that if everybody's benchmarking in the same way, because triage guides a lot of the length of stays and a lot of the funding. So depending on how many, for instance, CTAS 1, 2s, and 3s there are in an organization, it actually dictates how many physician hours there are for the emergency department. We want to make sure there was a timely access to appropriate care, specialists, and tests, improve flow at the back end. So initiatives like Discharge at 11 are something that came up as a result of these initiatives. Running also cost-effective ED, avoiding overtime and avoiding lots of extra loss of funds, essentially. Making sure we address offload delays from ambulances, and decreasing what we call left without being seen. So those are people who would present, receive a triage score, and essentially not wait anymore. So the funding methodology basically had these, it initially was the top 5 measures, and then the last 2 were added. And I'll show you this in a table, but for instance, the first one, ED length of stay of patients who are admitted, is the time stamp between triage to the time that the actual disposition decision for admission. And the goal for that is under 8 hours. The second one is the high acuity non-admitted patients. So those CTAS 1, 2, 3s, the sicker ones, having to be seen, treated, and disposition, meaning they go home under 8 hours. The lower acuity, less than 4 hours. Time to physician assessment, time to inpatient bed, CDU length of stay, which is a clinical decision unit, which is a code we use for people who end up staying a lot longer for psychosocial issues or more complex monitoring. And the last one, offload times. And when you put it all on a table, this is essentially what it looks like. What's in blue is a P4R indicator. So we look at ambulance offloads, time to PIA, ED length of stay, time to inpatient bed. We actually monitor a lot more than this at the Ottawa Hospital. But again, if you don't measure, you don't know how well you're doing. Here, I'm going to share an example of the Ottawa Hospital's trend indicators. So we have, here's an example of different indicators. They each have specific targets. They each have specific definitions. And so when we look at the first one I have here as an example, is the percentage of patients that come into the emergency department and end up getting admitted. So the data here is from April 2018 to November 2019. The red line is a civic, general is orange, and yellow is corporately. And as you can see, it kind of goes up and down, which is what we expect depending on what's going on in the community. But overall, we trend these numbers. We report these numbers back to the ministry as part of our expectations. Here's another interesting one. This is the time to ambulance offload. So from the time the ambulance arrives and receives a triage to the time we actually take the patient off that stretcher, meaning that they've actually been put in a bed, in a wheelchair, or they're walking, and the transfer of care has gone on to the hospital. This one is measured in minutes. So as you can see, the civic and the general, civic is blue, general is orange. On average, if you look at April 2018, sorry, the number at the top is wrong. It's April 2018 to November 2019. So our numbers were fairly low, considering 60 minutes, 40 minutes offload times. And then as you can see, in June of last year, the numbers spiked. And for those of you who work at the Ottawa Hospital, in June, what happened? Epic happened. So Epic didn't delay the ambulances, but Epic slowed down the system. It caused the system slow down. So essentially, if length of stays on the inpatient units delayed by a small percentage, that all carries back to the ED, where the patients couldn't be decanted to move upstairs because everybody's staying longer. And it might be longer by a day, which doesn't seem like a lot, but all those days captured together turns into a huge percentage. So what's really positive about this is that we did spike up in June. There was a very long offload delay, and then essentially you could see that number trending down again. And going back to our process improvement project back in 2008, when we started doing improvements, there were things like ambulance offload nurse that were started. So those are non-traditional spaces where we would be able to put patients who met certain criteria in a space to wait until we can get them into the ED and actually relieve the ambulance crew. So that's a project that's still going strong right now, where we have 5 to 7 beds, depending on the sites, the general or the civic, where we could decant some of these ambulances. But the reality is they're still lining up. There's still a lot of them waiting to be decanted because of the overcrowding in the emergency departments. So how many patients do we actually see at the Ottawa Hospital? And I was really happy to see the statistics, because if you see here over the last decade, there's definitely been an increase. So blue is the general, yellow is the civic, and green is total. So we were seeing about 121,000 in 2008, and then that number is up to 178,000. So the increase per year is about 9 point something, 9.3, 9.5. Every year it would increase. So that's really validating why we have so many more patients in the department and there's so much more issues with flow, because we're technically seeing a lot more people. And when we actually break it down per day, so in 2008, the EDs would see about 165 people per day per site. So that's general and civic would see about that number. And today we're seeing about 250 people per site per day. Now, being in geriatrics, what really matters is how many of them are old. So that's really where we actually care more for. So the green line is the number of patients who are in the early cohort, so 65 to 79, and the blue line is the ones who are 80 plus. And what you can see is that the numbers are climbing steadily as the population is growing. So we see the numbers at the bottom for the two cohorts, and the bottom is the percentage increase per year. So about 25 to 29% every year we're increasing that cohort. So there are a lot more older adults. We know that it's coming, but this is actually putting it right in our face to see that. So what does this mean for older adults in the emergency department? So there's little evidence that shows that they use the ED inappropriately. And we see that. The GEM program sees that all the time. Frail older adults obviously need more length of stay. A quarter of them have some sort of geriatric syndrome. They have a high rate of hospitalization, a high rate of ED revisits, and we know they have a high rate of hospital-acquired complications. We see that in the ED, we see that in the inpatient areas, we see that when they come back for follow-ups. And has anybody been in the ED? You notice how much overhead paging there is, how loud the environment is. It's just not suited for older adults. We have a lot of overhead paging. There's a lot of chit-chatter in the hallways. There's bells ringing, alarms ringing. It really sensory overload. There's stretchers everywhere. There's overcrowding. It's a rushed environment. And why is it rushed? Well, essentially because the system is making us be more rushed so we could perform. They might not come in with their assistive devices, and the reality is we struggle having enough walkers and canes in the departments to serve our patients, make sure that they mobilize. The process is the physicians really want to fix the problem and send them back into the community. They don't really take the time to look at all those complexities of older adults that have slow evolving problems, or they have atypical presentation. Ageism is always a factor when you deal with older adults. And then systemically, just a lack of resources in general. So what are the consequences of not considering older adults in the ED? Well, there's incomplete and inaccurate assessments, and we see that all the time. There's misdiagnosis, deliriums that are called dementias because there's no collateral information. There's no other people that are there with these patients. Many of them have no next of kin. There's inappropriate disposition. They're sent home when maybe they should be admitted. They come back to the ED. They come back to the hospital for admission. It leads to premature institutionalization and essentially leads to functional decline. Now, we can't forget about our dementia cohort. So we know that dementia patients have, again, lots of ED use, lots of length of stays. Admission rates are really high. Hospitalizations, delirium, falls, you name it, mortality, everything can go wrong. It's also been documented that primary care providers fail to diagnose dementia, and not having enough collateral in the ED. Again, people don't go through the trouble of looking for that, because traditional medicine and emergency is really, treat and street, fix the problem, send them on their way. And often because dementia is a neurodegenerative process with no cure, the symptoms are slow, they're evolving, and they're under-recognized. And even in geriatric-specific EDs, cognitive dysfunction is often missed. We actually have, a lot of patients in our area that we see that are living with dementia, very advanced dementia, being cared for by their partners or spouses who have a lot of advanced dementia. And we end up seeing what I call the positive suitcase sign on a long weekend, the Friday where they just can't cope anymore, and they show up to the emergency department because they just can't do it anymore. So a lot more people are living in the community a lot longer with dementia. So in 2008, the GEM program was incepted. It was an opportunity to address these frail older adults when they come into the emergency department. It was to develop an innovative model to change how older adults are managed in the ED, and it was intended to address those high-risk seniors who had high ED revisits, functional decline. And the purpose was really to create an individualized and coordinated plan for each patient who has these geriatric issues so that they could stay home or in their retirement home. And develop a plan of action for these frail seniors who might have these high risks of decline or medical decline, and to improve their outcomes. And it was launched in our Champlain Lynn at 9 sites. And there's a total of 21 GEM nurses, some that are here in the audience. They receive specialized training and they complete targeted geriatric assessments. Now, the GEM process itself is a little bit, it looks really busy, but it's very simple. There, on the left-hand side is the way that the referrals come in, either that were referred by someone in the emergency department, be it a nurse or physician, that the GEM nurse either case finds on their own, or we have an administrative screen that shows people who are at higher risk, so they're older and they've had 2 ED visits, and those are all ways that we capture our patients. We complete what's called an ISAR score, which I'll talk about in the next slide. We're looking that they actually have a geriatric issue, because that's where we can have the biggest impact to try to reverse or optimize. There's a GEM assessment done in person or by phone, and then there's a discharge plan with coordination of care. Now, the people that we want to see are the ones who are medically cleared. There's a clear plan for them to go home. They've done all their testing. They've had effective pain control. They've walked. They live in our LIN, because that's where we can optimize the services in the community, and they don't live in long-term care. And this process has been in place since the model started in 2008. So this ISAR tool was developed in order to assist senior-friendly emergency departments. It was designed for people who are 65 and older, and it's a big predictor for people who need admission or long-term care. It's 6 simple questions that are screened by the GEM nurse with everybody that comes in. So what is the GEM assessment? The GEM assessment is essentially a standardized nursing assessment where the GEM nurse interviews the patient, the ED staff, the family, paramedics, home care, the retirement home, the pharmacist, the family doctor, anybody we can get our hands on to get some collateral. There's observations, and then there's actions, which include referrals and recommendations and teaching. And essentially what we're looking for is for those geriatric issues, regardless of what they are, how can we prevent them from getting worse or optimize their outcomes? Part of our referral process is to refer them to specialized geriatric services. These include day hospitals, geriatric assessment outreach teams, falls clinics, memory programs, geriatric psychiatry, geriatric rehab, and geriatric clinics. I didn't have enough space. I could have kept going on and on for our community supports, but the print was getting too small. On top of specialized geriatrics, we also engage the patient to refer them to community support services. These are things like the LIN Home and Community Care, the Going Home program, which is a wonderful program that provides transport, meals, housekeeping, personal support to our patients free of charge. Falls programs, primary care outreach for those isolated seniors, mobile crisis teams for those who are having issues with mental health, community centers, Champlain Healthline, Alzheimer's Society, Meals on Wheels, alert systems, exercise programs, and a lot more. So next I want to talk a little bit about the GEM Plus program. So the GEM Plus program is unique only to our Champlain LHIN. The Plus component is a critical factor that brings lots of organizations and service sectors together to support GEM patients. It gives urgent capacity response and accountability agreements to community support services and to specialized geriatric services to provide an advantage for our patients. And we actually measure the outcomes of our patients to make sure that they have the right services, the right time, the right place, and the right delivery by the right person. What this essentially means is that when a GEM nurse sees a patient and needs a spot in the community, for instance, at a day hospital or with geriatric outreach, they can have priority over someone who's not seen by GEM. And we know that this unique model has been extremely successful. Part of the model is also to have a governance program. The project leadership team sits every quarter and meets, and that includes all the 9 sites, their senior leaders, as well as the service providers. And they look at they oversee the program growth, coordination, and evolution. They set direction and policies, and they embrace a shared governance where decision-making goes through them. So if we're not spending in one section, then we could divert the money to something else. And how this works is essentially through the aging at-home budget. $4.2 million is received every year, and that money hasn't changed since 2014. $1.2 million goes to fund the GEM nurses regionally, all their salaries. So that is not coming out of the individual hospitals. And then $3 million goes to community support and specialized geriatric services in order to get those priority accesses. So essentially 72% of the money goes to the spots in the community. So when we're done seeing the patients in the emergency department, they could have a rapid referral and a rapid access. So by purchasing these services, we're able to have more sustainable discharges for our older adults in the emergency department. Now, adding to this process is accountability agreements. So these are done annually with the different partners. There's metrics, there's money, there's finances, there's reporting that has to happen. And that's a formal way for us to keep accountability within the different groups that we partner with. So the APN, my role for the GEM program is unique compared to other GEM programs. They don't have the opportunity to have an APN. I work within the 5 domains of the APN role here at TOH. I develop different nursing standards, create new strategies for older adults, care in the ED. I am part of the recruiting regionally, so if there's GEM nurse turnarounds, I sit in on the interviews. I actually provide the orientation in the standard way, so like that if you're receiving a GEM assessment in Cornwall or at MOFOR or at Queensway or Pembroke, it's all standardized. We're all asking the same questions in the same way, gathering the same information. I meet regularly with all the GEM nurses in person, by phone, and site visits. And I also facilitate complex case management. In 2017, the GEM Plus program was actually recognized through Accreditation Canada as a leading practice. And it really helped us really go on the right path to recognize that what we're doing is really important to the older adults. So what do we measure in terms of the GEM program? Well, we measure the total number of patients that were seen and sent home. We measure percentage of patients who return to the ED within 30 days or those who get admitted. We measure also ED length of stay, total number seen and discharged home and admitted, number of GEMs completed by phone, and destination referrals. The ones that obviously admitted is not our patient population, but often GEM nurses are either involved too early or unveil medical complexities or social complexities, and so it turns out that they have to be admitted. So that's kind of how we capture that data and share it through the LHIN. This is a number, so over the last maybe 10 years of, so the discharge home, they've had a GEM assessment. If they've been discharged home is orange, and a GEM assessment, both that are admitted and discharged home is in blue. So essentially what you see is a trending, obviously the line is going up, but you're seeing the space between those that are admitted and discharged home is narrowing, and that just goes to speak that the GEM nurses are capturing better patients or the declining referrals that they know will be sent home a lot earlier. Here's another number we like to capture is the telephone assessments done. This is over the last 2 years. You could see the rates were quite low, 30% for rural, 37% in urban in Q1 of 2018, and now we're hitting 50% both ways. And that's only because of the ED overcrowding. The length of stays are so long that patients just don't want to wait anymore to have an assessment completed. Now, in terms of where we refer, most of our business goes to the day hospital, different day hospitals in the region, also to geriatric assessment outreach teams. And then our lower rates are for geriatric psychiatry here in Ottawa. Yellow is for geri-psych in the rural sites, and then the GA in the community for outside of Ottawa is our last one. So who is this GEM patient that we see? So on average, the age is about 81. The genders are about 65% female. And the top geriatric issues that have been essentially the same issues over the last few years is mobility, falls, and pain. Every GEM assessment has the geriatric issues identified, and then we capture these all on a quarterly basis, and it really fits into the patients that we see. So what are some current challenges with the GEM program? So essentially the funding hasn't changed since 2014, 2015. It costs a lot more now for a GEM nurse than it did back then. Yeah, we're still performing at very high levels, which is positive. So the other challenge we have is that ED overcrowded with admits. There's less physical space to see people, and there's more unconventional spaces. So in the image on the left, my left, we have conference rooms that have been diverted to patient care areas. And we also have, this is the hallway, just a random hallway at the civic emergency where my office is. They've put curtains there so we can have more non-conventional spaces to hold admitted patients because we're bursting at the seams. Other initiatives that are out there is there's 3 colored zones. So zone 1 is emergent care, which is a monitored area here at the Civic. Zone 2 is observation, and zone 3 is urgent care. And this is now populated in the waiting room, so people know when they come in, depending on which zone they're going to, how long they're going to have to wait. And this fluctuates. It just happens that day that zone 1 was 38 minutes. Zone 2, which is our observation area where people can lie down, 12-hour wait time. And zone 3 is 4-hour wait time. So it just captures a little bit of what we see. We know that the ED volumes are really high. There's a lot of patients, and a lot of patients could benefit from GEM. We have a lot more phone consults because patients just don't want to wait any longer. We do have a cohort of patients that we struggle with. Those are the ones that are at significant risk, yet they refuse all the services. And they keep coming back to the emergency department, and they still continue to refuse services. And those are the ones that our GEM team really worries about. There's way more caregiver burden, more spouses caring for each other, a lot of dementia in the community, a lot of undiagnosed dementia. And then the question of resource versus need, not unique to TOH. A lot of our physicians, our emerge physicians, they just want to know, is the patient safe to go home? And really that puts us in a situation where we're starting to unveil some things that takes us away from our GEM work in order to address those geriatric issues. There's an inability for the ED staff to really understand what's out there in the community, what the patients are using. We also have a lot of cases that come our way where the window to optimize them has closed, and they're really on the trajectory for long-term care, and there's nothing we can do at that point, and they're just failing in the community and just at home longer. Also, 8 out of 9 of the emergency departments that have GEM have lost the presence of the Lynn Home and Community Care Coordinator in the ED. And although we do have access to the services by calling someone, the physical presence of that person that's gone has actually put a lot more burden on the GEM nurses because we're constantly being asked, do they have services? Can you initiate services? And really adding more burden to us because of that change in that landscape. We also have the privilege of 0.5 physio at TOH at both sites and social workers present at the same time as GEM hours, which is wonderful. We need more. If social workers are pulled into a trauma or a VSA, they're really not there to see the frail older adults who have been sitting there all day who are struggling and need more supports. So there was a program evaluation completed in 2012-2013 and actually published in 2015. It was a case costing analysis for the GEM program. And to no surprise, it actually demonstrated a lot of cost savings. There were 7,700 patients that were enrolled that were 75 and older. They lived in the community, in home or retirement homes, and they had a triage score of 3, 4, or 5. 932 of them received a GEM assessment, 6,000 did not, and the cost avoidance for this program was $1,900,000, which equated at the time to 1,310 bed days. So we know that the program works. We know that it's been well positioned to have success. Now, recently we have had a new member join our team, Maris Pryor, who's spearheading the next program evaluation and really looking at those questions to understand how do we optimize with what we have with the current limitations, the funding that hasn't changed over the last few years, and the ED environment. Are we using the best practice that we can? Are we delivering the services that they need to be delivered? Are we making sure that where we're referring our patients they're getting what they need? Other questions that she's examining is to what extent does the GEM program impact the ED and acute care? What are the true values of what we do in terms of avoiding those admissions and ED revisits? And lastly, how do we support building capacity within the ED for the non-GEM people who actually need to understand about geriatrics a bit more? So when we're looking at the future direction of the GEM program, we have this wonderful opportunity starting in April 2020 to have a geriatrician embedded into the ED at TOH at the Civic Campus. This is going to be really new and exciting times for us. They're going to have two streams of patients to see, so some that are admitted to medicine who could potentially be optimized in the ED or brought onto A1. And the other one is to partner with GEM to see some of these older adults who require rapid intervention and have the geriatrician there to be part of that dyad, to start those case reviews, to start intervening in eMERGE. We know with the few visits that we've had of geriatricians in the ED doing some trials that it's already brought up new learning to the eMERGE physicians. The other day we had one of the geriatricians come to rounds and they were discussing the cases at handover at 8 a.m., which is something that they do every morning. And they were able to pipe in the geriatrician and provide some recommendations right on the spot and really change the lens of what they're doing. So we know by osmosis, just having the geriatrician in ED is going to change everything. And the goal is really to create a rapid access model for some of these older adults that are seen in the ED by a geriatrician and then brought up to our day hospital and maximize their outcomes. The other future direction projects, so CTAS has implemented a frailty modifier, so we need to get better at using that. What that means is once a CTAS, you're collecting all the data, if you deem that the patient is considered frail, then if they're a CTAS 4 or 5, so less urgent or non-urgent, they get bumped up to a CTAS 3. Just because we know that frail older adults will require more time, and we don't want to get penalized with our pay-for results because they're older and they're frail. Now, that doesn't work from 3 to 2 or 2 to 1. It's just for the 4s or 5s that they could be bumped up. So we need a bit more of a boost on how to maximize that frailty modifier. And then lastly is about creating a better fall risk reduction strategy in the ED. It's something that all the EDs have been working on individually, but hopefully we'll have a better coordinated approach. So essentially what I really wanted to bring to light today was looking at the different ways that the ministry is almost setting our older adults up for failure with our Pay for Results program and our expectations to be quick and deliver services, decrease length of stays, and just understanding that the older adults are far more complex and require a lot more services and time. So looking at those two together, it's a bit of a contradictory model. And I really wanted to bring light to that because I think as we see those lines of older adults grow in terms of the statistics and the more people are coming to the emergency department, I think we'll be more and more asking those questions on how to improve our outcomes for these older adults in the ED. And that's it.